Good evening, everybody. Welcome to our AACFAS Virtual Journal Club. I'm gonna just give it a couple more minutes for some people to join. Looks like we've got some people still joining us. Just wait a little bit longer. All right, looks like we're leveling off a little bit. All right, guys. Well, welcome everyone tonight to our monthly installment of the ACFAS Virtual Journal Club. I am Samantha Miner. I'll be your moderator this evening. First, I would like to thank PICA for their generous support of this program as always. We do have our special guest, Dr. Chickenelli, on the call tonight. He is the Chief Medical Officer at PICA. He is also very experienced both domestically and internationally as a podiatric surgeon, consultant, speaker, and educator in sports medicine, reconstructive surgery of the foot and ankle, diabetes limb salvage, including 28 years as a lead surgeon on humanitarian missions in pediatric surgery in Central and South America. How's that for the short version, Dr. Chickenelli?
That's great. Thank you. Welcome
Okay.
everybody. Welcome everybody. Happy to be
And
here. Love to support. Pica loves to support this for ACFAS and all your research efforts. It's just so important to keep helping support research for the profession. And look forward to hearing the articles and the discussion. Welcome everybody.
And just so everyone's aware, there should be a pop-up on your screen. Please make sure you fill that out. That just helps us with kind of measuring attendance for these virtual journal clubs. So we have the Wellspan Health Reconstructive Foot and Ankle Fellowship presenting tonight on tibialis anterior tendon rupture treatment. We have two fellows. We have Sara Judickas and Seth Wimbley. And we have Dr. Jennifer Mulhern as the co-director of the fellowship on tonight. And then we also have a couple of special panelists with us. We have the authors of our first article that we'll be presenting. We have both Dr. McAllister and Dr. Dufler on tonight, so they'll be able to give us some great insight on their article that we'll be reviewing. So with that, Sara, feel free to take it away.
All right, let me just share my screen here. Can everybody see my screen?
You can see the presenter tab.
Oh, well, give me a minute then, sorry. Let's see. That's not what I want either. Hold on. Me. Sorry, I had it pulled up, but it wanted to do its own thing. Let's see here. So I'm going to share. And now, slideshow, presenter view. Does this look like the presenter mode or does this
No,
look
you're
like?
good. You can
Oh,
start.
all right, thank you, everyone. So, as Sam said, I'm Sara Judickas with Wellspan Health Reconstructive Foot and Ankle Fellowship, and we are going to start our journal club with an article about tibialis anterior tendon ruptures. We realize this is kind of a rare pathology, so there's kind of limited literature and research available on this topic. But Dr. Dolfer and Dr. McAllister did a really great systematic review on this topic, and so that's the first article that I'm going to jump into. So the title of it is Tibialis Anterior Tendon Rupture, Surgical Treatments and Outcomes, a Systematic Review and Meta-Analysis. The inclusion and exclusion criteria. So for the patients that were included, the studies that were included in the systematic review, they had to have at least 1 year.
Sorry
Yeah.
to interrupt. I can't see your slides moving forward. I don't know if it's just me.
Seth, what do you see?
Doesn't move.
They're not moving?
Nope.
Oh, maybe I can't use presenter mode then.
Probably not. Be fine.
All right. We'll just do regular and forgive me if I miss a note, but it should be fine. So when I do it this way, can everyone see this?
Yep, you're
And
good.
flip it, it's moving.
Yep,
There you
you're
go.
good.
Okay. So inclusion and exclusion criteria, 1 year follow-up, it had to be a case study or case series. They had to have documentation of the long-term outcomes and it needed to be in a peer-reviewed journal. They excluded anything that was a cadaveric study, that was a rupture from a laceration or a rupture due to a systemic cause. They also did not include any cases where there were multiple tendon ruptures, so it had to be an isolated TA tendon rupture and it had to be treated surgically. And then they also didn't include any that involved a rupture secondary to a bone fracture. So really just an isolated TA tendon rupture. So they collected their articles in April of 2022 using PubMed. They searched tibialis anterior tendon and anterior tibial tendon and the word rupture. And then they screened all of the articles and ultimately ended up with 26 studies. Here is a table of all of the studies they included, the levels of evidence, the number of patients, the type of surgical intervention, and then these different scores that they use to look at the outcomes. As you can see here, there were 25 level 4 studies and 1 level 2 study, which we'll talk about later is actually a level 3. But these are all of the articles that were utilized for the meta-analysis. So for the statistical analysis, they looked at age, time between injury and treatment, and follow-up. And then for the meta-analysis, they did what you would typically do for a meta-analysis using a software program to help obtain the data. They looked at outcomes of each different surgical treatment being either good, fair, or poor. And then they also did an odds ratio with a 95% confidence interval. And anything that was statistically significant was a p-value less than 0.05, which is standard. For the different comparisons, they looked at direct repair of TA tendon ruptures. They also looked at studies that included autograft repair with several different options as far as tendons from that same patient. Then they also looked at allograft repairs and extensor tendon autografts, either using EHL or EDL. And then the last surgical intervention type was utilizing the TA tendon and either doing a turn down flap of the existing tendon or a lengthening. Then they compared the time to treatment. So it was considered it was treated acute in the acute phase if it was less than 6 weeks. And then it was considered a chronic rupture if it was greater than 6 weeks before the patient was able to have treatment. And lastly, another focus of the study was to look at where the anatomic location of the tensioning of the repair was. So whether that was actually within the tendon itself or if that required bony reinsertion with an anchor. So here you can see, I'll start with kind of the different tables that were included in the study. There was their first figure explains all of the studies that were included for direct repair of the TA tendon. There were 10 studies that had direct repairs, a total of 76 cases, and then they included the age, the time to treatment, and the months. And then, as you can see in the analysis, they have the odds ratio on a forest plot and the confidence interval. And similarly, they include another table for the autograft repair of the TA tendon rupture. There were 10 studies, 65 cases in this group. This is the allograft group, so there were only 5 studies that had allograft as a repair option for TA ruptures, and there were a total of 25 cases. The extensor tendon autograft group, which was either with the EHL or EDL, had 7 studies and a total of 41 cases. And the split or turn down TA tendon repair had only 4 cases, or 4 studies, a total of 10 cases. Then, when looking at time from injury to treatment, they have all of the studies that included injuries that were treated less than 6 weeks or in the acute group. So that's this table here. And then they have a table that explains all of the studies of the chronic ruptures that were greater than 6 weeks from the injury. And then lastly, where the tension of the repair was, whether that was in the tendon or with the bony anchor. And these are all the studies that had the tensioned repair within the tendon itself. And this last table is all of the studies that included a bony anchor for fixation and repair of the TA tendon. So all of those tables do a really good job of explaining or delineating all of the analysis and the available research and making comparisons. But to kind of sum this up, in the direct repair group, they had 76 patients, 53 reported good outcomes, 20 fair, 3 poor. So overall, good outcomes were reported with the direct repair. When looking at autograft repair, there were 65 patients that fell into this category. 45 had good and 20 had fair or poor. So overall, a good outcome. For allograft repair, they had only 25 cases, and unfortunately, good was on the lower side. So there were only 9 good reported outcomes and 16 fair or poor. So should be noted that this was different compared to some of the other treatment options. And then the extensor tendon autograft repair with EHL or EDL had a majority of good outcomes at 31 compared to fair or poor at 10. So something that was important to gain from this portion of the study that had statistical significance is that the allograft repair had statistically significant worse outcomes when compared to either a direct repair, an autograft repair, or specifically the extensor tendon autograft repair. Then when looking at the TA tendon lengthening, there were only 10 patients in this group. 4 were good, 6 were fair or poor, but I think that we're really limited with the amount of patients in this group to really extrapolate whether or not this was a good or a poor outcome. Then when comparing chronic versus acute, there was 159 patients when comparing this variable, 78 acute and 81 chronic. And there was statistical significance for this factor. So patients who were treated less than 6 weeks or in the acute phase, closer to the time of injury, had a significantly better outcome compared to patients who were treated in the chronic group. And this is kind of to be expected. We know that things that are treated from a more chronic standpoint tend to have poorer prognosis. So that did make sense to me. And then when comparing tensioning the tendon, purely tendinous versus bony reinsertion, they had 211 patients. 120 of them were the tendinous repair and 91 were the bone insertion. And there was no statistical significant difference between where you tensioned it, whether it was within the tendon or at the bony insertion. So the key points of this article: allograft repair has the worst outcomes compared to the other surgical options available. Acute treatment does better than chronic treatment, and tensioning the repair at the level of the tendon versus the bony insertion has a similar outcome. So that's what I have for my article summary. I don't know, Sam, should I just kind of go through these discussion points then?
I mean, does anyone have anything they want to kind of discuss just right off the bat based on that? before we go into the critical appraisal sheet? I think I would say, something I always ask myself when I'm reviewing these papers is this going to change my clinical practice? And based on this, potentially, right? Obviously, we want to try and diagnose these injuries as soon as possible, so that we can treat them as soon as possible. I think in terms of the allograft versus some of the other options, something that, maybe this was not available information and, Dr. Dufler and Dr. McAllister can definitely weigh in. But in terms of kind of the different procedures that were done, there's usually sometimes a reasoning behind that, right? Like if you can do a direct repair, I mean, there's a reason that's usually the most common. It's usually because the deficit isn't large enough that, it's amenable to be able to direct repair that tendon, right? But there are going to be some instances where, especially when it's chronic, that deficit is just too big that it's not amenable to a direct repair, or it's even so long that maybe you can't use an autograft or something like that. So I think there are instances where an allograft kind of unfortunately has to be used, and that it may be kind of, necessary that their outcome, maybe not necessary, that's not the right word, but it might be expected that their outcome is not going to be as great because, their kind of starting point was worse to begin with. So even though there's, some great correlation there, I don't know if there's some necessary direct causation because we just don't have all the information.
Mhm.
Yeah, if I may weigh in, good job, Sarah. That was super clean, looked really good. I wish I would have used that as my manuscript when I presented it 3 years ago. But I mean, the hard part about this is that some of the literature, I mean, we're talking about like 1995, so it's some Wild West stuff that I don't know if I would ever really consider legitimate. Like some of the autographs we're talking about are like semitendinosis. So like, what are you doing with the host site with that, I guess? And then you go as big as that and then as small as like the plantaris. And it's just like, man, I'm not too sure about this stuff. So I think that's what made teasing the data so hard with this. And I have to give like a ton of respect and kudos to Anthony Riddick. I can't remember his name exactly, but he did like the first systematic review on this in 2009, and it helps so much with the literature review. Um, I read this again for the first time in like 2 years, and I kept thinking to myself, like, what the heck did I mean with heterogeneity? And I looked it up and I sort of like really went down a rabbit hole, and it's basically just like a measure of variation and variability. And you can notice from some of the graphs here that like all of every single one of these groupings has very high
Yeah, the
variance,
I
which means
square
that,
value was very high
yeah.
for pretty much
Oh,
every
for
group.
sure. And
Yeah.
so when that's the case, like you're going to have a lot of, and I looked up some of the reasons for it, and it's hard to find reasons for it other than like you've got different surgeons, you have this surgery that's not really done ever. Like it's a very rare surgery, and so like expertise is hard to come by with this, and so there's not really a standard. And I mean, speaking as someone who I do a decent amount of trauma, I maybe do like 10 of these a year. Like it is a very hard technical surgery to do. Like you have to try to get a primary repair at all costs, even like
Mhm.
trying not to do anything with those mop ends, like trying to tension the ankle as high as you can. I always bring the EHL tendon around, dock it, anchor it at the medial cuneiform, and you dock the EHB to the EHL then, which is really hard to find in some of these people, and you're casting them like full dorsiflexion of the ankle, full inversion, and then like full dorsiflexion of the at the MTP. I mean, it's hard to really come to conclusions because of how much variability there was with this stuff.
Yeah, for sure.
Yeah.
Very true. Good point.
Hey, Sam, I'd like to make one quick point for everybody on the cause of tibialis anterior tendon rupture that didn't look like it, excuse me, didn't look like it appeared in the article. And this is with the risk management and risk awareness hat on for all the participants. And it's errant cortisone shots that were intended to go into the talonavicular joint or the navicular cuneiform joint. And cortisone has been left essentially subcutaneous or even a little deeper near the insertional zone. So huge medical legal risk. I've seen several cases. Should
Or
be
from
less
a
frequent.
lapidus, like a first TMT fusion. I've seen that
Yep.
before.
The typical, that's for sure. The typical scenario that sort of rears its head a couple months downstream is patient comes into your office with a drop foot and says a colleague as well, they may not even associate it with it, but on your history, you ascertain that they've had an injection in the last 6 weeks or so for osteoarthritis of the midfoot, talonavicular joint, navicular cuneiform. And they don't necessarily associate it with that, but what's happened is they've developed a TA rupture. So, of course, it's not about throwing a colleague under the bus or anything like that. It's realizing that it's non-defensible in the med-mal world to be putting cortisone around tendons without an absolute minimum of immobilizing either cast or can't walk or boot for at least 4 to 6 weeks. That's just sort of the standard of care of cortisone injections around tendons. Obviously, TA here, but also Achilles tendon. Anyway, keep that in mind. Should be less frequent with ultrasound guided injections, being able to get directly into a joint and so forth. But keep that in mind because it didn't show up in the causes.
Yeah, for sure. And just to our audience, if you guys have any questions or comments, please feel free to put them in the Q&A box. We'll be more than happy to answer those or discuss those. All right, Sarah, why don't we move on to our critical appraisal sheet?
Sure. So, just kind of for discussion purposes, and then Sam, obviously you can mention anything specific that how you feel about this portion. But basically, I'm just going to go through some of these questions. One of them was asking that if the foundation of the study was good. I said yes, especially because of the rarity of this pathology. I think that, definitely putting something together on this topic is well-founded and the foundation was good. As the experts on the topic, is the idea sound? I think anytime we're able to put together a systematic review, which is the highest level that we can put together on a topic, even though they were predominantly level 4 studies, I think that that's a good sound idea. And then does it add to the literature? And I would say yes. Again, Dr. Dolfer said that it was the last review, I think you said was in 2009 or something like that, the last available systematic review. So a more recent updated one was definitely adding to the literature. To discuss the methods, the sample size, again, overall it's low, but it's because it's a rare injury, but still good, again, considering what's out there. And then are the methods good? I thought there were good comparisons. The forest plot graphs really included all the meta-analysis well so that we could extrapolate information from them. Using a PubMed search and delineating the inclusion and exclusion criteria well is important. So yeah, I thought the methods were good. Looking at the results, do they make sense based on the methods? I'd say yes. Everything was easily readable and able to, the paper was organized well so that you could understand the results for each different type of surgical intervention, the timing to treatment, and then the tendinous versus bone reinsertion repair portion. So the tables and figures made a lot of sense. They used the appropriate statistics as well. And then overall, is this article giving good information? I said yes, and I agree with the results. Do they differ from my experience? I would say no, although I think I've only seen one allograft repair when I was a student. So for the most part, autograft, turn down, or EHL or direct repair is what I have seen. And then can we trust the results? I would say yes, I agree with that. And will it change my practice? Again, there was a lot of variability, but I think based on this study, we should try, as the specialists in this area, we should try to avoid allograft as much as possible. But like Sam said, if this patient has a really chronic injury and there's a significant defect, and sometimes that's all that you're left with, I think just educating the patient on the risk of having a poor prognosis is likely given the available literature. And that's all I have.
Can I just add a quick something, Sarah? I think that so I guess it's hard to explain the way that the statistics have to be put together, but basically, um, in a topic like this, you have to create something binary, which is really hard to do because you're talking about complications, you're talking about incisional things, you're talking about potential, muscle strength deficits and everything like that. And so, in order to make this binary, basically, like my good had to be like perfection, like 5 out of 5, like after a year, minimal pain along the incision, like no nerve issues, no repeat surgery, no like wound dehiscence. Like it was really, really specific, the perfection that I was trying to achieve with it. And so I guess the beauty of the study to me is that like the things that are statistically significant, like those are for sure statistically significant. Like there's something real in that data.
Yeah, that makes sense. Thank you for sharing. Yeah, with only having 10 minutes, I didn't have a whole lot of time to get into all of these specifics, but I'm assuming a lot of you have read the article, and if not, you can refer back to it. But each section really explains well, like Dr. Dolfer said, their outcomes as far as strength and having any incision problems and things like that. So, yeah, that definitely adds to the value of the study with how specific you were with making sure what was a good outcome was truly a good outcome.
And you're limited by what data is reported in the, studies that you're looking at, right? So if those studies don't do a great job of reporting, I mean, what I was always taught was like crap in, crap out. So if, they didn't do a great job of their data mining, then it's going to be tough for you to get some good data kind of out of it. So you did the best you could.
Great.
All right, sir. Do you mind controlling the PowerPoint?
Yeah, I
All
will
right.
stop sharing. Thank you, everyone.
Oh, let's see. Mhm.
So this article was actually one of the studies included in the systematic review, correct?
That is correct.
Yeah. Let me
So we
see.
get to take a closer look.
Yeah, so I'm sure Seth will mention this, but this was one of the studies. It was the one out of the 26 um, that was not a level 4 study, but I'll let Seth kind of touch on whether or not it's a level 2 or 3 or what it actually is.
All right, cool. So this is surgical treatment of the tibialis anterior tendon rupture. The listed purpose of this study was to compare between three different surgical procedures and their overall outcomes with VAS scores as well as patient-reported outcome measurements. The methods it was four surgical centers. They utilized 48 patients. They split it between three surgical procedures. The patients were interviewed for subjective measurements pre and post-operatively, as well as overall functional capacity. They did physical examination for post-op function, and they had an average follow-up of 30 months. Inclusion criteria was pretty simple. It was if you underwent surgical treatment for a tibialis tendon rupture, utilizing one of these three methods, and exclusion criteria was any conservative treatment or patients who had revisions or patients lost to follow-up. So these were the surgical procedures that they listed or mentioned. There's just direct repair of the tendon. This could be acute or chronic rupture. They didn't really, exclude people who had like a chronic rupture versus an acute. Reconstruction with a semi-T graft or transfer of the extensor hallucis longus tendon. These were the measurements that they did. So VAS scores pre and post operatively, PRLM or patient measurements. Activity level was part of that. And then when they had the results of overall patient records, they broke it down into four categories, which were very good, good, fair, and poor. They did ANOVA statistical analysis. And then we'll start getting into the tables for this. This was just a table mentioning their comorbidities and risk factors. They didn't really include it in their overall results or if it had effect on these. This is a very big table that's basically comparing the surgical techniques. When I look at tables, I like to split them up into each category so it's easier to read. So that's what I'm going to do here. They mention these in several categories. So what they kind of differentiate this is they do pre-injury activity level, post-activity level, and they broke it down into low, moderate, normal, high. And then after they measured pre and post-operative, they measured the overall difference. And they broke this up into down two segments, which in short means if they were high activity pre-operatively and then they dropped two spots on the list to moderate, that's what they call a down two. And so that's just to measure if they had post-operative patients who had a significant decrease in overall activity level since their injury, even with surgical intervention. And then they also, like I said before, did VAS scores and the patient-rated post-operative results. So this is further breakdown of the table. This is just VAS scores for the EHL. They had 11 patients. The overall improvement was 34 on the score, so from 48 to 82. This is the same exact chart for the semi-T. They had 10 patients. Pre and post-operatively, they had 44 to 87, so 42 improvement. This is the chart for the direct repair. So this was the group they had the most patients in. And what they found was they also had a 34 improvement, which was the exact same number as the previous. So this is the overall table for surgical repair. This table is a little bit different in the sense that it changed the groups to indirect and direct as opposed to three separate groupings. The indirect is anything that's not the direct repair, obviously. If they use the semi-T or if they use the EHL transfer, this went into that group, and they tried to differentiate if there was any difference between, maybe there's a difference between direct repair and any type of alternative surgery in terms of like a graft or a transfer. And this is just the overall table of all the patients combined and how they did overall. So the statistical significance was after comparing all these, they found no statistical difference from their measurements between the three surgical procedures in terms of clinical outcomes, which is different than the systematic review we just discussed. And upon discussing the variability factor when we were using allografts and things in the previous study, I'm thinking perhaps because these were all in the same areas and the same surgeons did them, there's probably some significance in that, in the fact that they were doing it the same way each time, or they were using the same graft and kind of picking the same factors when doing these procedures that might have changed things. Um, so these are additional results, not mentioned in their overall purpose, but they did list it in their discussion and their results. So they basically were stating there was no overall relation between EAS scores and patient-reported outcomes between ages. However, they did state that there was a difference between age and patients who stated good versus fair and very good versus fair. And what this meant to me is basically saying older patients were more likely to say that their outcome was very good as opposed to just good in general. But they had the same amount of patients say fair in both categories between younger and older groups. Um, and then there was no significant trend for higher versus lower age across the results for poor, fair, good, and very good. What this basically meant is that when you broke it down in each age category, they had the similar amount for each of these categories based on like percentage of those patients. So if you went into the older age group, 25% said this, and if you went to the younger age group, 25% said the same exact thing. So no overall difference in distribution for the four groups. So this is just the key points. It's exactly the same thing. It's just listed as a summary. No difference between the three procedures listed, and then no difference in age-related outcomes as well. So does anyone have anything to say before the discussion aspect of this?
Do you guys have the critical appraisal sheet for this one?
Uh, like
So,
this purple tab?
well, this is just general discussion points, but we always do our critical appraisal sheets, and I can pull it up kind of once we go through this initial kind of this discussion part. I can pull it up afterwards if you guys want. I think we'll
Sure.
have a couple minutes to do that.
Okay. Um, if no one has anything. So is the foundation of the study good? Yes, I think it's a good idea to, you know, have the same surgeons doing the same procedures to overall see if there's patient-related measurements that are different or satisfaction rates. I think patient satisfaction and activity level is a major player in our surgical decision making. Is the idea well founded? Yes, same answer. As an expert, is the idea sound? Uh, I said somewhat. I think the paper has a good idea and it has a good goal, but at the end, they start to mention a lot of other things that they don't say is their goal. And I don't know if it's to add more information to the paper or make it more valuable. I just found it hard to read to get to the actual results we wanted to talk about in the beginning. Does it add to the literature? Same thing. I'm unclear on that, uh, just based on, we have the systematic review that says something different than what this says in terms of allograft isn't as strong, but this paper says it is as strong. So that's where I got with that. Is the sample size good? Yes, it's good for this situation, but it is very limited to the 4 locations, and it only did have 48 patients, so it needs a lot more in terms of sample size overall, but I don't think it's bad for this situation. Are the methods good? Yeah, the methods are good. It's subjective, but most patient measurements are subjective, so I think it's still a good study for that. Do the results make sense based on methods? Yes. Are the tables figures adding up? Yes, but they are hard to decipher. And if you look closely at the tables, their numbers don't line up horizontally, or they're grouped in different categories and spaced a little bit off. So that's one thing I noted. And are the appropriate stats used? Yes. Overall, is it giving good information? Unclear. I think the goal of the paper is mentioned well. I think the additional information is a little bit unclear and hard to read, and it doesn't necessarily stay the same throughout. Do I agree or disagree with the results? also unclear. I agree with the initial point that if there's no statistical difference in the three procedures, I can agree with that. The remaining portions of age-based results is a little bit unclear to me. Do the results differ from your experience? No, but I have not done any allograft. I've only done EHL transfers and direct repairs. Can we trust the results? I don't know why I said no. Yes. Will it change your practice? No. It's a small sample size, and the systematic review had different results. So that's pretty much everything I have for this article.
Yeah, I would say for this problem, I think their sample size was probably quite large compared to a lot of the other, case series and that sort of thing on this topic. But yeah, I think for a normal study for us to like if they had done a power calculation or something like that, which would have kind of told us how many patients they would have needed in each group to give us some statistical significance. I think that's something that makes me take these results with some grain of salt, because their groups, once they broke them up into, two groups or three groups, the sizes were quite small. So it's hard to know if it was powered enough to actually reach statistical significance or not. So that definitely gives me pause on their results to some degree.
You know, let me add one risk management sort of tip to the conversation, which is what I always like to do in these sessions. Hopefully, it's helpful to young professionals. Always be aware of where the article was coming from, where it was published. This is from Germany. And when you think about standard of care considerations in private practice, if there's an allegation against you, what are other people with similar training in your similar area doing for certain problems? And so that's a big one here compared to, well, specifically to what Seth just talked about, the difference between the meta-analysis and then this article and allographs and so forth. So be very careful about using an article like this as perhaps a referenced defense for yourself in your local community if it doesn't jive with what's being done in your local community, either private practice or in the local ivory tower or referral hospital. Always be aware of that with articles. Where are they coming from?
Yeah, for sure. All right, I just wanted to go through this really quick. So this is the critical appraisal sheet that I was talking about and that we typically go through on these journal clubs. So this one would be the one that we would use for this study because we're basically looking at how patients did in different types of treatments, right? So based on kind of what therapeutic treatment they were given. So this is often what's used for like randomized controlled trials. This was clearly not that, but this is still kind of the relevant critical appraisal sheet for us to use. So the first question for this one was the assignment of patients to treatments randomized. So the different treatment groups, was it randomized?
Yeah, I don't think it could be randomized. Like
No,
we talked
because
about, if
yeah,
you need a graft, you need a graft.
yeah, kind
You
of
can,
unlike what they stated, this is not a level two study. It's not prospective. Everything that they collected in terms of their data was retrospective.
yeah.
So this could be a cohort study, which would at kind of the highest level of evidence would be a level three. So no, the patients were not randomized. Were the groups similar at the start of the trial?
Um, in certain categories, yes, but also, there's the age variance between these patients that we can't account for. There's a relative length that they had for like acute versus chronic, but that was also still variable. They had a large difference in overall chronicity of these injuries. So I would say
Yeah.
no.
I would say unclear because, like that first table that they showed with all of the comorbidities, they didn't tell us in which group those patients fell. So we don't
Yeah.
actually know, like, were all of the people with comorbidities in the semitendinosus group? Like, we have no idea. So I would definitely say that this is not something that they did a great job of clearing up for us.
That
We
was
just
one
don't
of my
know.
points where I mentioned that they add extra info, but it's almost not used anywhere.
Right.
It's just
It's just
like
not well
mentioned
organized.
and then never mentioned again.
Yeah.
So I spent time reading it and then I was like looking in the discussion for it and I couldn't find it. So
Hmm.
Yeah, sometimes when I read articles, I call that like fluff. Like they're just putting in information to try to add to the paper, but they don't really actually do a good job of drawing in its importance to the actual study.
Hmm. And aside from the allocated treatment, so whatever their surgery was, were the groups treated equally? So during their post-operative protocols, um,
from my
the
understanding,
rehab.
yes. They said they all had the same post-operative sequence and they all had the same measurements and post-op schedule. So I'd say yes for that.
Okay. I'm glad they mentioned that, but at the same time, it's hard for me to believe that at multiple different centers, because right, this was like a multi-center study, I believe,
Yeah,
that they're all following the exact same protocol. Um, I
yeah,
just
it
find
was
personally, I
four.
find that a little hard to believe. But at
Yeah,
least they did address it in the method.
yeah. I'm gonna give them the benefit of the doubt and say they said it. So okay.
Okay. Were all patients who entered the trial accounted for, and were they analyzed in the groups to which they were randomized? That second question isn't really pertinent, but were they all accounted for?
I'm not sure I understand the question based on the randomized portion of this.
Right. So when it's a prospective study, you basically will have some degree of patients who basically drop out during the course of the trial. This was a retrospective study. So everyone that was included at the beginning was included at the end.
Yeah, they excluded everyone like in the exclusion criteria, but those were like the only people excluded from the study was if you didn't finish your post-op protocol.
Mhm. So I think the answer would be yes. Were measures objective, or were the patients and clinicians kept blind to which treatment was being received?
No,
Yeah,
they
so
were
that was,
subjective measures and the patients were blinded or randomized, so
yeah, no
everyone knew what it
blinding was
was.
done. And then this next part is about like relative risk and that sort of thing. There was no control group in this. They all had some sort of treatment. So we can't really measure any sort of relative risk or anything like that. So we'll kind of skip this kind of more statistical part. But see how that kind of helped us analyze this paper a little bit more critically. I think these are just kind of really helpful. I always refer back to these appraisal sheets. They do have one for meta-analyses and systematic reviews as well, but we're running a little bit kind of short of time here, so we won't go through that one. I will hand it back over to you guys unless anyone else has any other comments. Dr. Dufler, Dr. McAllister, Dr. Mulhern. All right, so I'll hand it back over to you guys if you want to, if you need to share your screen again, feel free, and kind of explain to us a little bit about your fellowship, what you guys do.
I don't really need to share my screen. I can just talk.
Okay.
We're Wellspan Health Reconstructive Foot and Ankle Fellowship. We are recently added to the Wellspan community. We were private practice before. Um, hasn't really changed much overall. The same criteria kind of fits our fellowship. So our fellowship is pretty well rounded. We see a lot of pathology. We work with 13 podiatrists, and we're currently working with an orthopedic attending who's a little bit farther out, but I go see him like every other week. Um, as far as pathology goes, we do reconstruction in the rear foot, flat foot, cavus. We do ankle fusions. We do, osteotomies of the rear foot. A big thing that I didn't see a lot of in residency that I've been seeing quite a bit of now is we do nerve pathology. So we'll do like common peroneal releases. We'll do superficial, deep things like that. Um, as opposed to your traditional like tarsal tunnel releases. So that was interesting. Um, We're not very heavy on trauma, but anything reconstructive is kind of what we do on a regular basis. This is also a program where you have several surgery days a week, but you also have several days in the clinic where you run an independent clinic where you have an attending kind of around if you have some questions or if you want to, maybe book a case for yourself and you want to ask some questions on, do you think this is the right procedure? Do you think this is a good, post-op protocol? They're always there to kind of help you, do your planning and help you out if anything goes awry. But it's a very, self-run situation. You'll get out of it what you put into it. They're always there to help you out if you need them. If you ask them for anything, they're more than happy to, work with you. Everyone we work with is um, very easygoing when it comes to being able to ask them questions and have a great conversation person to person, as well as being professional at the same time. So that's a good thing for us. Call is every other week. There's two hospitals. It's not like residency call where if you get called, you have to run in there in the next 15 minutes and answer it. It's if it's an emergency, go see it. If it's not, you'll figure it out. Um, Other things, I guess we could talk finances. 88,674 plus benefits, 17 PTO. You have educational days, you have job interview days, health, vision, dental. Um, we already mentioned attending variety. You'll go to courses. You can go to pretty much as many courses as you want, as long as you get invited by the program. So we just did the Striker and we did the Arthrex course. And if you want to do additional courses, if companies invite you, you just have to ask. And generally the answer is yes. I haven't been denied a course or anything like that. So it's, like I said, what you want out of it is what you get out of it. If you want to do more courses, you can do more courses. Other than that, we also have local labs that we can go to whenever. There's an Arthrex lab around the corner. Um, Stryker runs labs. I don't know if I can name drop companies. I should probably stop doing that. Um, but
Maybe.
there's labs for any company in the area. I'll stop naming them, but they're around and you can go to them when you want. And I have no affiliation or I don't make money from those companies, so my bad on that.
You have no
Um,
disclosures to make.
no disclosures to
Good.
make. And that pretty much summarizes it. It's a very autonomous program with a lot of variety, great attendings to work with. There's a lot available here for you. You'll get pretty much anything you want out of the program as long as you ask for it. That's how I describe it.
Have you guys chosen for, obviously not next year, the following year yet? Are you guys still interviewing?
We have, yeah, we have the next 2 years picked.
Okay,
So, yes.
gotcha. Sarah, do you have anything you want to add?
Not really. I think Seth said it all. If anyone has any specific questions, you can definitely reach out to us, or Dr. Younes, shoot us an email and we can kind of talk more specifics. But yeah, it's been a really great program. All of the staff, and attendings are super welcoming and excited to teach. So we've both really learned a lot and, yeah, we obviously we're biased, but we definitely would recommend this fellowship. You're gonna get not just additional surgical training or clinical training, but you'll also learn billing and coding. And yeah, there's just so much variety. It's been great. So that's all.
Are you
The
guys
only thing
excited to be done?
Yeah,
Yeah.
it's sad, but it's been good. I think we both feel very confident at this point. The way that the fellowship was designed, with you working with one attending one half of the year, Dr. Mulhern or Dr. Younes, and the other half, I think really allows us to get kind of full spectrum of what both of those providers do. And then obviously the other attendings on top of that. But yeah, no, I think we're both feel very prepared and ready for our jobs.
Nice.
the only thing I was going to add to that is we sort of pride ourselves on seeing the patient from start to finish. So seeing the patient in the clinic, working them up, trying the conservative therapies, making the recommendations for what surgical procedures are going to do them well, and then taking that patient to the operating room, walking them through their post-op course. When you have a complication, making these fellows have those hard discussions with the patient, so that they get that full experience, because surgery is surgery, and we know it doesn't always go as planned. So it is heavy surgery, but we also make sure that they're getting to see those patients all the way through the treatment plan. So when they're on their own, they can manage those patients as well.
Yeah, super important. I completely agree with that. I think the majority of what I do is kind of being a cheerleader for patients. And so knowing how to handle patients before and after surgery is, I mean, you're going to spend way more time doing that than actual surgery. So agree completely. All right, guys. Well, great job. Um, Thanks so much for being on. Thank you to Pica and Dr. Chickenelli for being on here tonight and your awesome comments as always. And I hope everyone has a great rest of your night. We are all done.
Thank you all. Good luck to everybody.
Thanks for the opportunity. Good night.
Yeah, thank you.
Good
Thank you,
night.
doctors. It was a great session.
Thank you, Mickey. Bye-bye.
Good night.
Night, guys.